Okay, great. Hopefully that's presentation mode now. Thank you very much for everybody for joining us today. Really appreciate you being here. My name's Stephanie Bloxham. I'm Head of Health and Social Care at Birmingham Voluntary Service Council. We've got a couple of people here today who are going to be presenting, who can introduce themselves properly when we come to that part of the session. Also joined by Stephen, if you want to just say hello.
Hi, I am Stephen Raybod, Programmes Director at BVSC.
Thank you. As said, feel free to introduce yourselves into the chat for those who've just joined and say hello. Also, we will pick up any questions you have during the session from the chat. This meeting is building on from meetings that we've been holding roughly each quarter since the end of 2021. Focused on embedding the voluntary community faith and social enterprise sector in Birmingham and Solihull into the integrated care system. We have been working with our equivalent Carver, who covers Solihull on this work. Previously, we've been holding the sessions for each of the localities in Birmingham, and Carver have been focused on Solihull. For this meeting, this is focused on the whole of Birmingham, just based on where we're at with some of the updates for the sector. And to ensure that we're keeping the conversation going ahead of future meetings. Okay, so if you can just keep yourselves on mute when people are presenting, that would be brilliant. Obviously, please do unmute yourselves when you want to come in and ask a question. Feel free, as I said, to use the chat function for any comments, questions you have, and saying hello to the group. If you want to ask a question, you're also welcome to use the hand icon. If for any sorry, just admitting people. If for any reason you're unable to do that, then a physical virtual wave will come to you, obviously, if your camera's on. We are recording the session for those who've not been able to attend, so we will be sharing it with yourselves and with the wider sector as well. Just to say, the slides will also be shared with you all after the session. So the key updates that we'll be focusing on today. So we'll have a presentation around where the integrated neighbourhood teams currently are as part of community integration for Birmingham. We'll also have an overview of system, pace and locality footprints. There'll be an update on Fairer Futures Fund, where this is currently at, and also an update on where the small grants programme has gotten to. There'll be a brief update around the system-wide community engagement framework. There'll also be an opportunity for yourselves to come in and share anything that you would like to around the voluntary community sector as part of integration within Birmingham, and also a few items under any other business, including a new funding opportunity. And you'll be welcome to add anything there. Great, so I will hand over now to Darius and Claire, who are going to talk you through integrated neighbourhood teams, and I know that you have your own slides, so I will stop sharing and let yourselves introduce yourselves to the group. Thank you.
Thank you, Stephanie. Lovely to meet you all. I'm Darius, and I am one of the programme leads on the Integrated Neighbourhood Team programme. I'll hand over to Claire to introduce herself, and Karen as well, because Karen will talk to us a bit about comms at the end. And whilst you do that, guys, I'm going to work out how to use Zoom to share my screen. It's the first time. Give me a sec.
Morning, I'm Claire Terrington. I am an occupational therapist by background, but I'm the team manager for the East Neighbourhood Mental Health team. So I work as part of Birmingham and Solihull Mental Health Trust, and our service is fairly new, so it sits within GP practices, and liaises a lot of you guys. I think already I recognise quite a few names, so it's nice to see a few people. Karen?
Hi, I'm Karen Stevenson. I work as part of the comms and engagement team, and integrated neighbourhood teams is one of my projects. So I'm here to fill you in a little bit about what we're doing to engage with citizens. Thank you. Darius, are you sharing?
Can you see? Can you see
it's
what
not,
I'm showing?
I could, and then I couldn't.
Oh, right.
We could see it. If it's a problem, I can share my side.
I don't think. Have you got the latest slides? Apologies.
I've got the slides that Jenny shared yesterday.
Karen, have you got the latest slides? Would you mind sharing? Because I think there was an updated version. I can try again.
Yeah, no, let me see if I can.
Thank you.
Oh, is that? Let me just download it. I've got it open, but I'll just need to download it so that I can do it properly. Bear with.
So while you get going, I'll start. So So before we get into the detail of the talk, I just want to say I'm really glad to be here. So we're going to talk to you about an initiative that will eventually be rolling out across Birmingham in the sort of longer term, which really has the power of community as its core principle. And we recognise that for this to be effective, it does require a strong partnership with the VCFSE sector. So whilst today is about sharing some of our early thinking, we really are towards the start of this journey. So it'd be great if you could, whilst we're talking, think about how we best partner with you on this journey. So that's a kind of broad overview. I'm not sure how close anyone is to the integrated neighbour team. So we're gonna sort of assume it's sort of newish for most people and talk you through kind of where it's come from and the context around it and where the thinking's at. Thanks, Karen. So if you go on to the next slide. So about a year ago, there was a really important report released by the ICS called the Fuller Report, and it set out a vision for integrated neighbourhood teams. And at a high level, the vision said there should be an integrated neighbourhood team per neighbourhood or per PCM. And that team should be multidisciplinary and ultimately responsible for the health and well-being of the population in which it serves. And a neighbourhood or a PCN is typically sort of 20 to 50,000 people. And in response to this, Birmingham set up 5 pilot sites across 5 PCNs, so 1 in each locality. And over the last 4 months, my team have been supporting and designing and testing out how these INTs will support people in their community. So, and the vision that was laid out is for people to live longer, healthier, happier, and more independent lives in the neighbourhoods and the communities they call home. But as we all know, for many, this means living longer and often with multiple chronic conditions. And if we look at the graph on the left, with light purple, if you go to the next slide, please, Karen. With light purple representing the most affluent and dark purple representing the least affluent, we know that we're much more likely to have chronic conditions if you're deprived. And health inequalities are, of course, a problem that require a holistic approach to solve. And we sort of recognise that we need to understand the root cause of issues, which often lie in the social aspects of someone's life originally. Next slide, please. So yeah, so how do we actually prevent? This is the sort of key question of this whole program. How do we prevent and manage escalating needs and reduce inequalities? And if you go to the next slide, please. What the sort of Fuller report suggests and what we've started to do, some of them we'll talk to you about this today, is bring together sort of local authority, primary and secondary care data to identify Birmingham's specific population needs so that we can prioritise, so we can really genuinely prioritise proactive services at the right people where we think will have the most impact, recognising that there's limited resources and limited capacity in the system. So this is all about understanding people more holistically and understanding which people would benefit most from our support in a sort of very targeted way. So if you go on to the next slide, please. So there's kind of 4 key aims for the INT. So the first is embedding that sort of proactive prevention, so identifying people who would benefit most from preventative support and reaching out to them before they reach their next crisis point. And through this, we want to be able to avoid preventable sort of formal care activity. So we know the health and social care system, for example, is in crisis, and the model is quite unsustainable as it is. So reducing formal service use should be a key aim of this initiative. And by being more preventable, we expect we'll be able to improve the outcomes and well-being of people, so help them stay at home independent for longer. And finally, improve the sort of holistic experience of residents, so stop them being bounced around, give them a key point of contact who manages them through the process and through their time of need. So if we go one more slide, please. I just wanted to give you a bit of an overview of kind of the journey we've been on. So since we sort of kicked off in around April this year, and this sort of these 6 steps to the process that we're going through. So the first is we need to identify the cohort of people that we want to be able to support. So we're kicking off with an evaluation phase or a pilot, which we'll talk to you about soon. That's going to start in August. But the first stage to get there was to say, to identify which people we needed to proactively support. So what we did is we connected that primary care, secondary care, and social care data to understand a person, understand people more holistically, and we started to understand which people were the sort of highest frequency service users of sort of formal care and health services. And we talked a lot, and the system talks about frequent service users a lot. But what they traditionally do is they look at it through the lens of one organisation. So the acute will look at high frequency service users for the acute, and social care will do it for social care, and community health will do it for community health. But because this is the first time we've actually connected that data across the board, we've actually pulled out a very different cohort of people, and these are people that are using a broad range of services, and they're people that are frequent service users for a very long period of time. They're not people who are sort of short, sharp frequent service users. So these are people that are genuinely in quite a lot of need, and that's our starting point. And I think it's just worth saying that although we're starting with this high frequency service user group, and the reason we're doing that is we want to be able to we think we can show impact and improve the well-being of those people more quickly because they're already in receipt of services, and show evidence and sort of prove that we can have an impact. But the sort of medium to long-term ambition is actually that we move beyond these existing frequent service users, and that we start to look at tomorrow's frequent service users and other cohorts of people that we can proactively support earlier in their pathway and be genuinely preventative. But we're starting with this group. We then we can't understand a person purely through data, so we held a number of case reviews with I think 60 plus different people from the front line and from the community sector, and we went through 150 real life cases. So we went through some people's case notes in detail and understood them in detail. We looked to answer a couple of questions. We tried to understand which of these people's cases could have been preventable if we had intervened earlier in their pathway, and we also looked to understand with what sorts of interventions could that need have been prevented. And Claire will talk to you through some of the outputs of that in more detail, but we had some really interesting findings around that and the power of the community sector and the power of things like social prescribing and voluntary services and grassroots services as well. So there were our case reviews. We then said, given we then had a better view of which sorts of interventions we were going to were the most impactful for this particular cohort of people, we then looked to sort of understand those services in more detail. So we shadowed those services and started to understand how they operate, what their waiting lists were like, what their capacity was like, what the effectiveness is of those services, so that when we do go to deploy and this work and actually run a pilot, we're not just pushing lots of demand into a service without sort of understanding the context in which they're operating. So we got to that point. And then the most interesting bit is the sort of start of designing these new ways of working. So we've done a lot of design work with members of the voluntary sector and then all the system partners, predominantly frontline staff, to really think about, okay, so given this group of people that we want to support, given the types of interventions we think we need to offer them, how are we actually going to support them in an effective way? And Claire will talk to you about that in more detail. The last thing I'll say is we're about to move into that evaluation phase. The evaluation phase is very much about trialing those new ways of working in small pockets. And this is really important because this is where we're going to get really, really strong resident feedback on the ways of working that we've adopted, to see if they're actually impacting or not, and the impact on those residents' sort of outcomes and well-being and experience. So and through that process, it's a 12-week process, we'll be iterating and adjusting the sort of model so that before it's actually rolled out beyond the 2 PCNs, we're clear that the residents are happy, the staff are happy with the approach, and that is actually driving the outcomes that we hoped it would. So I'll pass over to Claire now, who'll talk you through some of the sort of snapshot findings that we've got so far. So over to you, Claire.
Thank you. Could I have the next slide, please? So as Daria said, we looked at the data and we did some of those kind of deep dives and things. So we started off with the data, And actually what it told us was that there was a small group of people, so 10% of service users, that took up most of the time within services because of the demand. So there was those people that bounced around from place to place, people who maybe had lots of physical health and mental health needs combined, but no one was joining up their care. And actually that's quite a huge chunk of time that is taken up from resources. That if we just join things up a little bit more, we'd be able to reduce some of that time people spent in the system. And not only is that a benefit to the system, but a huge benefit to the person. Nobody wants to bounce around from place to place. So we had a little think about, what does that look like? What might we need to add in? And who are those people? So if we move to the next slide, we discovered, oh, excuse me, hay fever's got me today, bear with me. We had a look at all those cases, and out of those 150 cases that we worked through, it turned out that 56% of those had some potential for preventative action. And what that means is, had we have done something before they'd got to all those appointments, we could have reduced the contacts that they'd had with services. And out of those, 45% of them were appropriate for INT discussion. So there was something we could have added by joining their care up together if we'd just had a more rounded, holistic MDT conversation between those different services. And that might not sound a lot, but when you break it down, that's a huge amount of time. And actually, if that only makes a difference to a small group of people, that's still worth doing, isn't it? Because that means people get a much better experience, and we can start to think about reshaping services. The people that weren't appropriate for INT conversation were those people who've had kind of end-of-life care, palliative care. You can't prevent chemotherapy, radiotherapy type appointments, and so actually there was little benefit for bringing them to an INT discussion. It was more about those more complex cases where things just aren't joined up together, with lots of potential to do that, I guess. So next slide, please. So we started to have a look at those cases, and we did some of those deep dives that Darius kind of referenced before, and we've looked at, had we have done something differently, what would that have been? And these are all the interventions that we thought would have been appropriate, that could have made a difference to people. So the purple ones are those things around social prescribing, so things that were very familiar to you guys, really. 4 out of the top 10 were within social prescribing ranges, so there was lots of thought around healthy lifestyle support, particularly around things like diabetes. But actually some of that practical stuff around menu planning and cooking, those sorts of things, rather than just signposting someone to a diabetic nurse. There was work around befriending that was absolutely needed to help people get to appointments, to help them navigate the system, to help understand the processes that services often put in the way that help prevent people getting the support they need. Actual social prescribing and support to families and carers. So there was a large number of cases where actually if we just had a conversation with the family, it might have made a huge difference to the individual we were working with. We could have helped pull some things together. The blue boxes are those things around, I guess, the more statutory stuff. So looking at care package reviews, medication reviews and community mental health support. So what could my team offer potentially in the community that might have made a difference? And some of that very much links in with social prescribing, befriending, all of those kind of holistic, person-centered things that help people stay well. And then the last 3 were more specific things around diabetes support, drugs and alcohol, and long-term condition counselling. And I guess we see in our service lots of people who've been diagnosed with a physical health complaint, and it's having a huge impact on their mental health. So we try and link those things together so that we know that person's receiving long-term support for their physical health, but also they're having some conversation around their mental health to make it a bit easier for them to help navigate the system and get support they need. Now, those numbers don't add up to 100 for 100% because it was likely people needed more than one intervention. And again, I guess that highlighted the need to join things up together so that people had a much better experience within the system and through their journey. Next slide, please. So once we knew what kind of people we thought we were working with and what sorts of interventions we might need, we spent 2 days working through what the process would look like for the person if they were to follow a journey of INT. So the identification bit is a bit around the data that we've talked about, bringing those bits together and having some expert oversight around that to work out who is appropriate for those conversations. We then decided that a holistic assessment with the individual was really important. And actually that should be a conversation, so a person-centered conversation that allowed that person to tell us what their issues were, what was bothering them, what could we do to help, what hadn't helped before, and had they got any of their own answers that might help bring some of those things into a much easier space. And actually we know that our services, so our statutory services, we're not good at that sometimes. We're good at asking questions of the things that we want to know. So we try to flip it around and think about the kind of questions that you might ask within your conversations with people. So, you know, that kind of like, what is your journey? Tell us about what's been happening for you, what's important to you. All of those sorts of questions should be the focus of that holistic conversation. Once we've had that conversation with somebody, that case is then taken for MDT discussion. So MDT is multidisciplinary team. So we would think about, actually, we've got all this information from the person and from the data. What do we think is the right support that this person might benefit from? And absolutely, at that point, we take into consideration that person's wishes and thoughts about what they want from their journey and what it should look like. Once we've had that conversation, there is support offered to the person following whatever intervention is thought to be appropriate. And the person that does all of these bits and pieces is the person that knows that individual best. So if somebody was receiving a service from my team, for example, I would go and have that conversation with them, and then I would offer the interventions. And if I can't deliver it all within my team, then I'd work really closely with other organisations to make sure that person gets the right care and support they receive. And that includes things like warm handovers between organisations, building those relationships and making sure people feel comfortable with accessing those different services. We know that people often drop off at those transition points, so we were really keen to include some of those warm discussions to make sure people follow the process through. Otherwise, we end up back in that whole revolving door kind of scenario. And then obviously, once people have engaged in that intervention, it's really important to check in and review what's happening for them. Is it working? Is it not working? What can we do to break down some barriers? Are there things that we need to tweak and change? And then it would go around back to MDT discussion again for kind of improvements and suggestions if needed. I guess what we haven't ironed out yet is how long that journey takes. And I think some of that will come through from the pilot potentially. So once we've started some work with people, we'll have more of an idea of what they need and what that looks like in practice. Next slide, please. So I think I've said most of these already, but actually the focus for INT is around having that really great experience for the person. So, you know, allowing people time to talk through the things that they want, being able to think about prevention rather than responding to a crisis or some kind of trigger point, making sure there is that continuity of care. So we know people need to build trust and relationships with people for it to be successful. So having that continued person that will support them through that is really important. Ensuring people are listened to and really heard. Their story is really important. People often have their own solutions, so we need to listen to that. And people need to be able to have a sense of control around their own health and well-being. We also need to have enough time for those holistic conversations. So we were kind of talking about, actually, you know, there's no point having a 10-minute conversation with someone. You won't get the information you need. You need that time to sit and understand the person's journey and the nuances of that as well, so people can feel that they've had their information gathered in a really sensible fashion. And that people absolutely need to tell their story once. People can't keep repeating their tales. There's often quite difficult, challenging things for them to talk about, and it's re-traumatizing for people to retell that time and time again. So some recognition of that. And absolutely, we want care to be the right care the first time. So that's why that conversation is really important. We need to hear what's being said, and we need to deliver that in the community, because we know that's where people live and breathe and stay well. And it's often the things on people's doorsteps that keep them really well and engaged in kind of that journey of recovery and progress. Next slide. So I guess in terms of who's involved in the INT, this is still in development really, but what we've kind of discussed is that there would be an INT coordinator who would kind of draw the data together and help coordinate some of those admin type things. We would need a GP so that we have points of reference to link back into the primary care network to think about what support they might need. We would think about a social worker from social care, OT from social care, community nursing in case there's any physical health appointments and issues, a mental health practitioner, and a neighbourhood expert, which would be someone from the voluntary sector potentially, so a social prescriber or a community asset map person, whoever it might be. But at the heart of that is the person themselves. So we need to work around the person to make sure that they are at the centre of everything we deliver. And then we could also add in extra people depending on the person's needs. So if there was drug and alcohol misuse, we might involve CGL in that. Or if there were issues with their children, maybe schools and early help might be relevant to pull in at the right time to help people with that. And then if you could just click again, please. I guess this is just a little bit of detail around kind of what that each role would look like. So we've kind of talked about the GP being that oversight and link back to the primary care network, the coordinator being like an admin person, the neighbourhood expert coming from the voluntary sector, and then the INT key worker, which is the person that really follows that process through with the person that I just described. So thinking about who the right person is to do that. So it could be the mental health practitioner if it's mainly mental health needs, or the community nurse if there's more community health issues. So making sure that we adapt that to the right case and the right individual. And I guess think about those people really gelling together, so the conversation can be had in a really sensible fashion. So I think that might be all of my slides. Cameron, is it you next? Or do you want me to do this bit? Okay, so what's next? So I'm really excited about what's next because the pilots are taking part in East and West Birmingham and I work in East. So it's absolutely thinking about, will this work? So we've got a 12-week pilot to deliver this process. It's going to start in August, hopefully, if we can get all the staff in place. And what we're hoping is that we can get some really good feedback from people that are using that journey, following that journey, using those processes. We also want those hints and tips of things that aren't working. So if the conversation isn't right, we need to hear that. If we're not delivering things quickly enough, we need to hear that. And we need to act on that to reshape the model and make it work so that we can roll it out across the whole of the system. I guess what's really important is to build some networks as well. And I guess that's partly why we're here today, because lots of the work that we will do will absolutely require support from the voluntary sector. You know, I know firsthand that all the voluntary sector organisations we work with do an amazing job, and you're the organisations and places that really keep people well. So it's really important for us to link together and have some of those conversations about what else we can offer to people. And we know there's lots of hidden things in our communities as well. So trying to think about, you know, NHS and social care don't have all the answers. We know that lots of the answers lie in our communities. So trying to think a bit more broadly about how that fits together. And I do think that is my turn now. So.
Thanks, Claire. Yes, so this bit is me. So as I said already, I'm Karen. I work in the communications and engagement part of the project team. And we are very busy with citizen and community engagement at the moment. So BVSC have been involved with the INT process since the beginning. They've been carrying out interviews and speaking to colleagues to see how it's all going. This is actually part of the ICB. This is a priority for the Integrated Care Board in Birmingham and Solihull. So we're doing lots of chats and information sharing with our colleagues. We've had 4 workshops with our INT colleagues, which have all been really, really well attended. The last one was last Thursday, which was really good. And you can really see how it's kind of grown from March to like now. To see it come to life is quite exciting. As Claire mentioned, there's been design workshops which the INT leads have been involved in. We attended a very lively discussion last week with the people from public services, who had lots of questions about what the teams would look like and what their experience had been of health and social care and how they joined up. And, you know, there was a real mix of stories. And there's other people that we would like to link in with. We've got Birmingham Council of Faiths, hospices in Birmingham. We've got an actual in-person event on Thursday at the Saffron Centre, which has sold out. Strange, I say sold out, the tickets are free, but all of the tickets have, all of the places have been taken now, which is really good. So we're hoping to get lots of discussions going on Thursday. Integrated, yes, we've talked about that. I was going to ask actually if it would be useful to have an in-person or an online session specifically with all you folks. If you wanted something specific for this, we'd be happy to kind of arrange that. So yeah, so there's lots happening. So, you know, if you've got any questions or suggestions, or you want to be involved, please do drop a line in the chat and I'll go in and have a look now. Thank you all for your time. Shall I stop sharing now?
Thanks all. That's great. Thanks so much. And I know we've been having, there's various comments, questions that have been raised in the chat, which I know Darius has been busy responding to. I think most of it has been picked up at the moment, but appreciate if people want to come in and ask anything, either that you've already raised in the chat or that you haven't yet, please do. I think there's been a lot of really helpful information there, so I'm sure people will have a lot of thoughts around that. So please do use this time if you've got some questions for the team to raise it, and we'll come to you. Sarah.
Morning all. Really fantastic to hear, so thank you. I've got a 2-screen thing so I can see you on this side and I'm looking at my questions over here. Yeah, I just have some, and they may be really obvious, so apologies if you feel you've covered them or it has been covered in the chat. But where I'm just interested, where the care coordinator role that's been part of the R's roles, is that sort of transforming to the one that you've mentioned as a bit of a INT coordinator, or is that seen separately with a bit of a combination?
I think it will, so Sarah, I think at the moment because we are only about to go into 2 pilot sites, and so there's only going to be 2 roles available and we're just trialing things out. I think at the moment we are being very, very flexible for all the roles as to where that role comes from, and it will just be about, at the moment we're going through a process of identifying where there might be surplus capacity in the east from a coordinator perspective and surplus capacity in the west, just to see if we've got the right structure available, so that when we do roll this out more broadly, we know we can be clearer on the roles that we need. Where those roles come from in the future is very much TBC, and we're so early in the journey, we just don't have that information yet. We wanted to just make sure we shared all of the stuff with you very early on, so that everyone's kind of comes on the journey with us. So apologies, not really clear answer, but hopefully that helps.
So it sounds like you're you know, that there is this kind of role, and the fact that you're being really clear, which I think is super helpful. Like, we need a role like this that achieves this.
Yeah.
If a place or an area already has one, then it's an opportunity for them to say, well, we have it's in the form of for example, care coordinator as part of the R's roles, and that fits in really well. And where someone hasn't got that, it's like, oh, there's a gap there, because we've got this clear kind of footprint of what is needed. And I think that's the really exciting part, is from what I've heard, there's a lot of confusion about who's doing what and how do they interlink, whereas having that as an opportunity to go, well, this is how they could interlink, and being really clear, then people could say, oh, we don't need this bit, we only need these roles. And I think what people want to hear is that obviously it's not being duplicated, that it's just being communicating that really clearly from your research, what, you know, in practice, what that looks like. Do you think sorry, I've got several questions.
I think that's a really good point, and I do think I think that as a principle is going to be important for all the roles. So we know that there's crossover, right, with what we're doing versus lots of other initiatives that exist out there. So before we do roll this out to 30 plus neighbourhoods, we need to do that whole mapping exercise to understand what other initiatives are there out there, what other roles are there out there which might be duplicative in some way, and make sure that we don't just roll this out blindly without ignoring the sort of wider context. So I think your point is applicable to all the roles.
And to some extent, you might not need to map or know that prior to, but just being clear about what it entails, and giving it upfront. If we were to roll this out in your area, have you already got these roles or not? What bit, you know? So I think, and maybe it's just wording here.
And that's why it will vary by neighbourhood as well, because different neighbourhoods will have different roles already. So absolutely,
and different PCNs will have adopted all the R's roles, some haven't, and so there will be variation. And it sounds like a great ambitious kind of time frame. But if you were to hold back trying to preempt or know that beforehand, that's probably a lot of work that actually just ask the question and just say, look, this is what it could look like in your area. What do you need? And and I think that's a really fantastic approach. I've got other questions. I'll chuck some in the chat. Just let Christopher come in, and if there's time, I'll come back in.
Thanks, Sarah.
Thanks, Sarah. Chris.
Yeah, well, thank you for a well thought and clear presentation, and I'm glad now that there is a plan, and hopefully that each surgery will now be turned into health hubs rather than just being there for treating people in crisis, and also that the community voice will be represented at PCN level. But I wanted to raise the issue of costings, because if you are taking the approach you're going to take, it's going to save the NHS money in saving doctors' time, but the money saved will not go to the organisations picking up the shortfall. So I think there's one individual not mentioned who should be there in your team. That's a fundraiser for the groups you're going to use. My own organisation, which is a gardening charity, we've reached the limit of people we can take, and to expand the opportunities in our organisation, then you probably need a full-time officer to supervise people if you're going to refer them. So I think I would like to see what your financial plan is for the operation you're undertaking. Thank you.
That's a really great question. And of course, let's be honest, a lot of this is about, I think everyone's starting to recognize that formal care isn't well, it doesn't have capacity, but it's also not the right answer for a lot of people, especially when we're talking about preventive support. That means more people will be coming towards the community, and therefore there will need to be funding available. So Christopher, it'd be really great to catch up, actually, because I think your point around having a fundraiser as part of that sort of core team is a really good one. So if it's all right, I'll drop you a note about it, and we can sort of perhaps get talking. Thanks.
Great, thanks, Chris. Sarah, did you want to come back in?
Absolutely happy to, if there's time, but please do. I put one of them in the chat around kind of obviously this particular group that you're looking at may need that multidisciplinary team around them. Do you foresee, though, whether that would actually be needed every time? So if the more you're preventative and proactive in our approach with health and well-being, that actually not everyone needs a big team around them in order to make that progression. And we do hear often in the social prescribing world that quality conversation in itself, either with a social file link worker or someone that in itself can be really mobilizing. So I just wondered if you had any thoughts around that already from the research you've done.
Yeah, I'll come in, and maybe Claire, if you've got a view on that. So again, really good question. I think I mentioned at the start, we're looking at these sort of quite complex high frequency service users to start with, where that sort of MDT wraparound, that sort of intensive support and is more relevant and applicable. As we move down the sort of triangle of complexity, and we can become more and more preventative, and we deal with and we support people who are not yet frequent service users and therefore but could be in the future. Definitely see a world where we have a different model for that, or alternatives, which is more light touch and more nimble, I guess. We're probably a year away off being able to look beyond this high frequency service user group, because it's still quite an important, a big group and an important one. But I can certainly see that being the direction of travel for sure.
So I think yes and no. So I think that yeah, absolutely, I agree with Darius's point. As we move forward, you would like to think that people would need less input, because we would have a better process and think about prevention more. But actually, for that to happen, there needs to be a culture shift in the community as well. So I work in East Birmingham. People don't often come and ask for help for lots of different reasons. And so there's a piece of work to do, I think, around kind of, I'm not re-educating because that isn't really the right phrase, but kind of just sharing some knowledge and information with our communities about these are the places you can access support. That doesn't have to be an NHS team, it could be anything, but there is something about how do we encourage people to look after their own well-being from the very beginning. You know, we don't teach stuff in schools anymore. We don't talk about things in the community very often, you know, as people. So there is some work to do with both bits. I think until we can have some of that, then we're still going to need some MDT discussion. And I also think there is something about, I was often the only occupational therapist in a wider team of nurses and psychologists and stuff. If I wasn't in the room, nobody talked about occupational therapy because I wasn't there to say, have you thought about this? And so what we don't want to do is miss out any of that information. So you would hope over time that you would build that skills and expertise, but that remains, you need that kind of consistent MDT to build that knowledge and expertise. And just to go back to the point about the funding for the voluntary sector and stuff, we are doing a piece of work within our service. We know that we refer to the same sorts of organisations all the time for support because it's really good. So we're doing some work with commissioners to feed that back in to say, actually, we know that we need these different organisations. You need to fund them better and rely more upon them to do things that are helpful for people. So we don't have all the answers. That in itself is a shift as well, isn't it, to invest a bit more into communities and stuff. So yeah, so I think, yes, absolutely, there can be a light touch, but we need to do some work around community understanding and stuff as well before we get to that point potentially.
They're really good. Can I, if you don't mind, just come back on there's some exciting things going on that would really support both those responses. So a kind of community connection sort of training that you can do once it's a bit more supportive of a community hub, and I know West Birmingham are particularly interested in exploring a kind of community hub model, which really aligns with what support we're offering with the whole community approach at National Academy of Social Prescribing. So I just wanted to flag that because I think it really aligns, Claire, with some of those things that you were saying about how the community can in itself become more sort of self-sustaining and supporting each other in a everyday, but supporting each other to know that there is this a community resource and where it is, how to access it in various ways, and in ways that if English isn't your first language, in ways where you've got maybe mobility issues, etc., it's all accessible in different formats. So interested kind of speaking to anyone. I have raised that with sort of some lead in West Birmingham around kind of this would be a stage that you could adopt once you've got that kind of embedment of hubs. And then the other point I just want to make around the investment in voluntary community-based social enterprise groups. And I'm hearing a lot about some do have capacity, some don't have capacity, and really getting that balance for both. Even if you've got capacity, you still need to sustain and fund and ensure that flow of money is there. There's really exciting work in Derbyshire. I've just done a session on it, sort of articulating and doing a bit of modelling work, and it's all about kind of that relational model, and this is really helping. The sort of work would really support that because you're really identifying those roles and how they interlink, and that really does enable a better way of working. So again, would be happy to share resources that supports this work wider. I'll be quiet now and I'll put some other questions in the chat. I see Caroline and Stephen had their hand up.
That's all very helpful. Thanks, Sarah. Stephen, you did have your hand up, but I'm assuming.
Just to come in very briefly and say, I really like the name. I think it was neighbourhood coordinator. I guess just to say it's been a long time prior to this recent period where the neighbourhood voluntary sector didn't have a light shone on it. It's now having a light shone on it brilliantly. There are lots of cross-city and condition-specific organisations that don't necessarily function on a neighbourhood basis. And it would just be really important as a part of the skills profile that the people within those roles have an understanding of those as well. So we are quite a complex sector, and certainly things like, and you had them, but the drugs and alcohol provision, which is in the sector, and the community mental health support, which is in the sector, is done on a citywide basis, and just important that they've got access to that information.
Thanks, Stephen. Caroline, did you want to come in?
Hi, thanks. Sorry, I've had a not the best connection this morning, so apologies if this has been covered, but I wanted to ask, in terms of this work, from our experience working with the Sparkbrook Children's Zone, where we do have a kind of multidisciplinary team based in a PCN, trying to offer some holistic assessments and services. One of the pieces of learning is that people don't ask about our people's basic universal rights being met. Have they got enough food, clothes, security of their housing, condition of their housing? Are they safe in their house? These kind of questions. And one of our doctors said, and until working in this way, she didn't feel she could ask those questions because there was nothing she could do about sorting some of those things out. And we can't magic up, 100,000 new homes, and some of those things we can't do. But actually, the cases where we can really address that kind of frequent user scenario is often where we start addressing those universal needs first, because otherwise, it's very difficult to move on. And I just want to find out if there's anything around some kind of universal needs assessment that is part of this work, or if it could be incorporated. It's our sample of learning is quite small at the moment, but we would be keen. We are a children's service, and I'm aware that most of what you're talking about is really related to adult services, but I don't think, we work with families, a hungry child has a hungry parent, so I think it has relevance to adult services as much as children's services.
Absolutely. So that holistic conversation should absolutely cover some of those things. The people that we see that come through the door for our service, they've often got mental health problems because they don't have those universal basic needs met. And it is super important to point them in the right direction for those things and be able to help out with those kind of basic things people should have. And you're right, it might be a children's service, but children don't live alone, do they? They live in a family. And I guess that's why some of the work that we highlighted was around those family conversations and making that shift. So people don't live in isolation. People do live as part of a community of some description, whether it be a family or a group of individuals. So I think it's really important we have those conversations. I guess my thought around kind of what goes into the holistic assessment and conversation, as an OT, I would ask those things automatically. They make sense to me. Why wouldn't you ask those basic things? I guess there is something about us making sure they are part of that discussion, so written down as an indicator for people to fill in a question or a box, whatever it might be. But yeah, whatever you can share with us and help out with would be amazing, Caroline.
Okay, I know those conversations just don't happen enough at the moment, and actually, sometimes it's really simple to help people, and even if that's addressing 3 or 4 or 5% of need, imagine what time you can free up, from that. And it's not that there are easy solutions out there, but that needs to be part of the package, because we're too often finding out this information way too late.
Caroline, if you've got I'll have to grab your email afterwards, but if you've got, because we're in the process of designing what that holistic conversation looks like and the kind of things that need to be thought about as part of it. So if you've got something that you think is really useful, that's working for you, we'd love to see it and learn from it and build it into what we're doing, if that's okay.
We're happy to be part of that conversation because we have variations, but we also kind of looking at updating some of that. There is a standard kind of pediatric screening tool that we're already using. So yeah.
Okay.
No.
Thank you.
Thanks, Caroline. Sarah, did you want to come back in? I've seen a few questions that you popped into the chat as well. And just to mention to others, I have said that certain comments, questions that haven't yet been picked up can be taken away from the team, because it may be that the answers aren't all quite there yet, but do need to be considered as this develops and moves forward. But I'll go back to you, Sarah.
So I didn't realise I still had my hand up. So equally, if you need to move on, there's no pressure to respond. If it would be better to respond in the chat. So yeah, I don't mind either way. Would you like to?
There's no other hands at the moment, and I'm assuming, Darius, Claire, how much longer do we have before, as I know you needed to leave for another session?
Yeah, I need to drop off at 11. Apologies. I'm not sure about Claire.
I can stay.
Thanks both. Sarah, feel free if you want to come in. We can, if we stay another 10 minutes, if others have questions and want to come in, please feel free to pop your hand up. And then we'll move on to the other parts of the session.
So one of the questions was around, you mentioned not the person having to repeat their story. And I've heard this quite a few times, but then what I've not heard is, what are you doing differently? So what is it that is going to enable someone to, when in conversation with a professional or as part of that team, that they're not having to repeat their story? So what I probably could say better verbally is that I mentioned in the chat, what someone might have, you know, part of a system, it might, their stories kind of being captured in some way by someone else, and I've put that in a system, but often that doesn't necessarily get relayed back to the person who's getting a handover, and the opportunity for them to say, well, I think you might have misunderstood, or they might have miswrote what I originally shared, or it's really changed. And so I think there's an opportunity where they can kind of shape their story, so that it's not just this, we have to kind of say it once, hope that someone captures it, and there's a lot of like emphasis on getting it right, and there actually is more about an ongoing dialogue about, oh, that's really good to hear that this is the perspective you've got from the notes from a previous meeting, so I don't have to repeat myself, but I would like to adjust it and share with you that actually since then this has happened, or they didn't quite capture that right. And I just wondered, what's been your thinking around that, in terms of, one, a system that practically supports that process, and two, the approach that you're taking around really individualizing it and having that personalization with someone about being heard, and then having a chance to change that story or add to it.
I can come in on that. So I think it's again a really good question. So there's a few things that we're thinking about, because I think that is a really, that the person not having to tell their story multiple times is core to this initiative. So the first thing is that before we reach out to them, before that holistic conversation and make contact, the coordinator role will be to take all the information that already exists on the systems, and understand and pull that person's story together, and also reach out to the people that have been in closest contact with that individual to fill the gaps in and gain a deeper understanding. So that's what we can get through data initially. The second thing is the person will be identified a key worker, and that key worker within the INT will be their main point of contact throughout the process. So they will know their story from the start, and they will continue to know their story, because it'll be a consistent person. And the third thing to say is that we are developing for the first time, an integrated case management tool. So that will be accessible by all the INT members, regardless of which organisation they're coming from. And at the moment, that's not possible. And so that person's story that will be in this case management tool will be shared across all the systems, which will mean that you're not looking at someone through the silo of your organisation. So there's lots of things happening in that space to make sure that it is genuinely a tell your story once process. We'll get some things wrong. We're going to learn from the pilot, but there's lots of things in play.
Fantastic. And is that because that's quite similar to a social prescribing case management tool, in terms of that's probably partly why they've been designed, is to allow for multi-sector, only drawing on, i.e. maybe NHS data that is relevant, and holding it in a place so that you're not
overwhelming.
the
or-
sensitivity. Yeah, so there
Yeah.
there isn't the whole history and sensitivity, and there can be then that access and mutual space. Is it something similar to that, or have you got something else?
It will
in
be
mind?
similar, but potentially better, I think, because the social prescribing tool is only accessible to social prescribers and maybe one or two other organisations. This will be genuinely integrated across the different organisations, so social workers, the community health guys, all the sort of formal care partners. The thing we do need to work out is how the voluntary sector feeds into that, because I don't think that integration of data has happened before, and that's going to be a big IG conversation that will need to happen. And so honestly, we haven't solved that bit yet, but in terms of the rest of the system, then yes, it will be accessible by them all.
Okay, I'll be really interested to hear that update if
Yeah,
because
it's being built at the moment, so we can
right.
we should be the sort of MVP version, the sort of the basic version will be available for the pilots, and there will be a much more developed version before it's actually rolled out to all the PCNs. And I think the other thing to just mention is that, again, another thing that we're sort of the way in which we're designing the MVP version, the sort of the basic version, doesn't enable residents to log in and view their own story or update their own story. However, that functionality exists, and we expect that we'll turn that on before it's rolled out. So again, bringing the person into that will be really, really powerful, I think.
I agree, absolutely. And it would be interesting to know how it integrates with, if there is social prescribing case management systems, how they integrate with each other, because maybe they play a role, or they might not, or you might not need to have that as well. And so there's a cost saving from a ICS perspective that you could do without duplicating, because if you are putting a lot of resource in developing something, which to some extent arguably if something else off the shelf, it already exists, it's the why that wasn't used, what this does differently. Because some of my understanding is that it could have done that, but I haven't done the full research around it, so
the difference is, I mean, this is quite a technical conversation. It's one we should definitely pick up. The difference is the social prescribing data, the social prescribing system data will only include data that has been collected via social prescriber. This system will have data on a person's acute attendances. So if they've gone to hospital recently, that will be flagged to the key worker. That won't be possible through the social prescriber system. It will have information on someone's care packages. It will have information on someone's GP attendances recently. So it has a lot more information already connected. That's already been connected. We're just building the case management tool on top of that. So I think it's more powerful than what the social prescribers will have access to at the moment, because they will only see things through their world.
Well, at the minute, Birmingham doesn't have that tool, so I think it's a good opportunity if Birmingham's already developed something like that, but they don't duplicate with the link, because I think social prescriber link workers could perhaps use something like this if it's similar but
definitely
includes more. So
agree.
That's just more of a flag to Birmingham.
That's fine. We can pick up that more offline, Sarah. That'll be great.
Absolutely.
Darius, do you need to go?
Yeah, apologies. So I'm going to drop off now. Thank you so much for letting us come and speak to you. It's been really, really great to hear all your questions, and I've got some actions to take away to reach out to some people following that as well. So thank you for your time.
Brilliant. Thanks, Darius.
Bye.
And Claire, thanks for picking up, responding to various questions in the chat. Thanks for staying with us as well. And Karen, Christy, Caroline, you did both have your hands up. I just want to double check before we move on if you did want to come in and ask anything.
I mean, I just wanted to talk about the system, and that we already have something like Easton's that where and the information governance and all of that exists there for children. It doesn't hold medical notes, and having having tiered access to, so what I think it would be really useful that we don't have to join the police and GP, and all sorts of agencies up to another system. It would be great if there can be discussions that are not just focused on adult services, and then we get, we already have several systems in place. I'm not saying eSINs is the answer to everybody's prayers. It definitely isn't, but it does work well. What I would say is if there's a new system being rolled out that's parallel, just consider the risks, because we also know that there's some people on multiple systems and they don't use those systems. They only use one system, which creates like a facade of integration, but actually it's just chaos and confusion. So yeah, sorry.
Thanks, Caroline. Claire, did you want to respond at all to that, or I guess it's more for noting for moving forward, because it's a really important point. Oh, you're on mute, Claire.
All right. It is really important. So my team, we have to use the GP system and Rio within secondary care services, and so that in itself is really risky and really tricky to manage. So I absolutely don't want a third system for us to have to use. I guess, Caroline, if you could, I think Darius will probably email you, so if you could take it up with him and just feed that back, because there was some debate around the access that we give to other organisations to the data. I am a firm believer that you guys need to have access to all the data that we have access to, because we all work with the same people. But I know there are information governance things around that and data sharing protocols and all that kind of nonsense that goes on. But the Newton group are doing all the digital support and stuff. It's way above my pay grade to talk about digital solutions. I don't understand a lot of it. So
we already have, a big complicated, which maybe could be copied and picked up just to save time. But I think unless we talk about it, we just land up with systems that aren't working. And also you have to request case by case access. It's not like you have these systems and you have open access to everybody's data. You don't. You have a case holder, and that person will get, works out who's will give access. So I think it's not beyond possibility.
Thanks, Caroline. Caroline, I'm assuming it might have been an accidental hand, but just
no,
I
was just going to say that I think the issue that came up at the beginning of this process is that everyone has different systems and none of them linking together. This is the idea, is that it's bringing that everyone can access, everyone that needs to can access this. So obviously it's in its very early stages, but Caroline, if you want to bring it up with Darius, that's my understanding, is that these people that need to access it, so adult social care, NHS, voluntary services, as we said, it's in the very early stages, but the idea is that everyone that needs it should be able to access it at the appropriate level.
Thanks, Karen. Great. Okay, well, we'll move on to the next part of the session. Just to say thank you again to our the team for joining us, and for all of the responses, and for everybody for your contributions. And it's been very important points and questions and comments raised as part of that, and a lot to take forward. And I'm sure there'll be other conversations that Darius and Claire can pick up with you as well. And obviously for those who are joining on Thursday, I believe the session is going to be positioned a bit differently. It is going to be focused around integrated neighbourhood teams. It will be very interactive, so please do attend, where you can contribute even further then, and anyone else from the community.
Thank you.
Carol, was there anything on that? Great.
No,
okay.
no, that was Stephanie, if you're allowed to, if you could send us this transcript from the right, we can just make sure that we get everything that's been asked and commented, and to ensure that we include everything that's been said. Thank you. Thanks, everyone.
Will do. Thanks so much. Okay, great. So the next part of the discussion is going to be focused around the various footprints for Birmingham. So thinking about, and Solihull, thinking about system, place, and locality. So we'll just share slides, and Stephen will be presenting this part.
Okay. I'll be quick, and this is really just to make sure that you've got the overview so that all these different pieces of information slot in. One of the things I'd just say to Caroline is that the community integrator, which INT is part of, is focused mostly on adults at the moment, but they know they're going to focus on children and young people, and they're looking at the different way in the future, and they're looking at the different ways in which the focus on adults will trip them up with children and young people. And I think the thing you've raised around shared case record, and that already in effect existing around children and young people is really important. So we'll flag that into the governance. So just going to do overview of system, place and locality footprints for Birmingham, Solihull, just explain a little bit how they function. Some of this will be familiar to some of you. So the first thing I'm going to start with is just an overview of the different footprints. So the system, which I'll go into detail a bit more in a moment, actually covers Birmingham and Solihull, the local authority footprints. The name of the system is obviously BSOL ICS. The governance structure is Birmingham Solihull Integrated Care Partnership. At place level, we have on the footprints of the local authorities 2 place partnerships. So we have Solihull Place Partnership and Birmingham Place Partnership. Obviously, they're a very different size. At locality level, which is the 200 to 250,000 population, we have Solihull, and then we have West, Central, South, North, and East Birmingham. And then underneath that, we have a neighbourhood level. So and I think this is quite important, because often the NHS and the ICS, when it's talking about neighbourhood, it's talking about that 30 to 50k population, which is quite big for a neighbourhood, but it's also talking about a PCN footprint. I think, although I'm not 100%, the integrated neighbourhood teams are functioning at a subdivision at the moment in pilot phase, at subdivision of neighbourhood level. So it's important, I think, for voluntary sector organisations to understand how they're going to integrate with these different structures. Could we have the next slide, please? So, okay, at system level, generally we're referring to all of the provision, citizens, hospitals, mental health services, the ICB, which is obviously the commissioning function for the NHS, does most of the internal commissioning, primary care, public health, and social care. Now, all of these things function at place and at neighbourhood, or most of them function at neighbourhood. But in essence, we've got footprint, we've got activity that cuts across the whole system at this level, as we have with the voluntary and community sector. We go to the next slide, please. So place, and this is in some ways quite strange ICS language. If something is being described as being decided at place, that means it's being decided at Birmingham level or Solihull level, and that's not the local authority is describing it. It's very much Birmingham Place Board and Solihull Place Board. Can we go to the next slide, please? Okay, so at place level, there are partnerships, the NHS organisations, GPs, local government services, third sector partners, and they contribute to the local population's health and care. So as you can imagine, Birmingham is a very densely populated place partnership. It's responsible for arranging and delivering care services that take place at space. They set objectives that respond to population needs. They bring together system partners. There's a real focus at place level on preventative and proactive and supporting joined up care, and they play a critical role in driving change. So currently, although we'll be looking at this, I sit on the place partnership for Birmingham, and it's got various representatives. It's got GP representatives, it's got representatives of public health, from adults, from children, from the Children's Trust as well. If we go to the next slide. So underneath place in Birmingham, we have the, I'm going to call them the ICS localities. There is a city council locality model that's made up of the 10 constituencies that you can see listed, but these are the double localities. Now, this is important because what you're going to see over the next 12 months or so is the rolling out of decision making and activity at locality level. So if we go on to the next slide. So the decision making will be through locality based partnerships. They'll play a role in delivering health and care services which are more tailored for people. They'll have access to their data. They'll be undertaking population health management. They could have, although this isn't yet determined, they could have their own budget, and hopefully that will be to determine where money is going to be spent. They can bring different service providers together, and there also can be a forum for citizens and communities to be represented. So one of the challenges at the moment is that quite often, if you're we have decision-making structures which citizens and community organisations can't get access to. So hopefully this will alleviate that. If we go to the next slide. Okay, so neighbourhoods. So neighbourhoods in ICS language are the footprint of groups of GP practices working together from the care networks. In every locality, there are a number of primary care networks, each of which covers around 30,000 to 50,000 residents. It's quite likely that smaller community-based organisations are working at this footprint, and some of their integration will need to be undertaken at this. So what you might find is that resource comes in at locality level, so the locality partnerships, but that the actual integration that you need to undertake will be, say, it might be undertaken through integrated neighbourhood teams, and that will be done at a neighbourhood level. Okay. I've rattled through that really quickly just so that you've got the sort of very broad overview of what is happening, so that you can locate the other activity within that. Are there any questions?
Thanks, Stephen. And just to say, we will definitely share all of the slides so you can refer back to them along with the recording. Great. Okay. Well, if anyone thinks of anything, feel free to pop it into the chat. Stephen can respond there, or we can come back to it towards the end of the session. So sometimes I know it's a lot of information to digest. Okay, we'll move on to the next part of the session, which will be initially Dan Brown talking about where we're currently at with the Fairer Futures Fund, and then I'll come in afterwards with a few updates around the small grants programme. So if I can hand over to you, Dan, have you got slides to share? Or do you want me to share this?
No, I'll tell you what, Steph, I'll do it. I'll give you a rest. And also it keeps my skill levels up by working out how to do it as well, which is important. Brilliant. Okay, here we go.
Thanks, Dan.
Okay, so firstly, hello everyone. My name's Dan. I am a locality network manager, and I work for Birmingham and Solihull Integrated Care Board. Specifically, I work for Birmingham Place, which you'll now be familiar with, because Stephen explained how it all works, which is good because it means I don't need to. Some of you will have seen me before talking about locality partnerships or attending these events to talk previously about Fairer Futures Fund, which is what I'm going to do today. And hopefully, for those who did attend those previous sessions, you'll note that some of your feedback has been incorporated into at least one of these slides and into the thinking that goes on behind the slides and what I'm kind of going to go through today. So firstly, apologies for the boring slides, not as exciting as the Newton ones, which makes me very sad. But I will rattle through them nonetheless. And the second thing to say, really, which is the headline of this update, is that essentially we are still working on the Fairer Futures Fund. So this will be a relatively brief update, just to tell you kind of where we're up to, but with a promise to come back when there are some more concrete proposals ready to get engagement on and to share across the system. So a lot of you will already know what the Fairer Futures Fund is, I think, but for those who've not heard of it before, it's a large pot of money that's been set aside by Birmingham and Solihull Integrated Care Board. Some of that money will be top sliced off the top for what's called a Fairer Futures Fund Challenge Fund, and that is an amount of money that will be used by the Integrated Care Board at a system level, so at that very top level that Stephen described, for initiatives covering Birmingham and Solihull. Below that, funding is then has been allocated to the Birmingham and Solihull place committees for them to manage on behalf of Birmingham or Solihull. Obviously, I've been working on the development of the Fairer Futures Fund for Birmingham specifically, and I've got a colleague who's been doing likewise for Solihull. So the kind of the state of play with Birmingham's pot of money is that the Birmingham Place Committee has agreed a structure for the Fairer Futures Fund, which sees it being cut into 4 sub-funds, which I've listed there, but I'll just briefly explain what they are. So there is a citywide small grants fund, and that will be grants of up to £15,000 to be used for addressing health inequalities on a citywide for communities of identity or experience who are within Birmingham. Then there is a larger pot of funding, which is partnership fund, and that is intended to be sums of money from 50,000 up to £500,000, although please just take these figures with a grain of salt because they are subject to final sign off once we've worked up all the proposals. And the Citywide Partnership Fund will be bringing together partners to work on major health themes within Birmingham. Then kind of going from that city level to locality level, which again Stephen explained in his presentation. So there will be small grants, again, of up to £15,000 available for localities to use within a locality, and they will be for a range of activities. But really important just to say that with the differing amounts of money, the smaller amounts and the larger amounts, the expectations in terms of delivery will be commensurate with the amounts of money that are on offer, and also commensurate should be the ease of applying for those pots of money and the associated evaluation that goes with it. So you shouldn't be expecting the same level of impact and evaluation for £15,000 as for £500,000, which hopefully will make sense. And then the final one is a locality partnership fund. So similar to the citywide one, that will be an amount of money allocated to a locality to build partnerships to address major health themes and do things on a slightly bigger scale. And as it says there, it just repeats the amounts of funding that are available from those 2 pots. And we are envisaging will take place over a 3-year period after funding is granted. Just press the next one. Okay. So beyond the signing off of those 4 sub-funds, what we have underway at the moment is 2 different task and finish groups in progress. So one of them is working through what the management arrangements will be or could be for those 4 pots, and they'll be working up options that will be signed off at Birmingham Place Committee. And the second task and finish group is working through what the target priorities are, again, for each of those 4 sub-funds. So there's lots of stuff in the ICS strategy that you probably would have seen, lots of metrics and clinical themes that are talked about. So it's just really, really important to make sure there is a clear focus for each of those 4 sub-funds so that they are being directed against the most appropriate areas of that ICS strategy. And that includes clinical engagement with colleagues from across the system. Just really important as well to take you through a number of principles that are guiding the work of those 2 task and finish groups. So it's really important that the priorities of the 4 sub-funds, once they are kind of established, will have a clear link back to the Birmingham Solihull ICS strategy, and that they are measurable so that the impact can be assessed. Now, some activity that's funded by the Fairer Futures Fund will be very, very specific and focused, but we still think it will be possible to establish how it contributes to the overall aims and objectives in the ICS strategy. And to that end, it's really important that Fairer Futures Fund activity will be kind of evidence informed, and it will be focused on impact. You'll see there the third one. So principle for the fund is to reduce health and wellbeing gaps in outcomes for communities of place, identity and experience, and to provide resources and momentum for preventative approaches and to address wider determinants of health and health behaviours. Really important that it's led by communities and professionals who work in those communities, and that it's co-designed in that way. And the aspiration is that the fund will leave behind a legacy. So whether that is in working or business cases, whether it's in helping to establish future funding, or it's just creates an impact that lasts beyond the lifespan of the fund. As I mentioned before, so processes for application and evaluation should be proportionate to the funding which is being offered. And again, it's just really important to note that the Fairer Futures Fund is not intended to fill budget gaps or to provide support for existing statutory services. It's about trying to find new ways of doing things, new solutions to old problems. And if I just move to the final one. And just one final point, really. So for the 2 smaller grant sub-funds in particular, just really important to flag up that in working through those priorities in the task and finish group, we'll make sure that the ask is specific and realistic. However, I'll just kind of urge you all to have a look at the ICS strategy if you haven't already, because it will give you a lot of the information about what the system and Birmingham in particular is trying to achieve, what are the kind of priorities, what are the really important health needs. And I think it will help you to understand the context in which the Fairer Futures Fund will be operating, albeit there will be a lot more detailed information that will come along once we are ready to kind of publish the detail that sits behind all of those 4 funds. But I think it will just give you some good background if you've not already read it, and just to kind of prove that point, although I'm not going to go through these in detail. These are the ICS medium-term 5-year metrics that are in the ICS strategy, and you'll recognise the importance of a lot of the stuff on there. And then also there's a whole range of different health inequalities which are in the strategy. And again, these are the types of things that we will be looking for funded activity to impact. So I'm going to stop sharing now, Steph, if that's okay.
Yes, thanks, Dan. That's great. I know there have been a couple of comments in the chat. If anyone does have any questions, please do put your hand up or come in. Sarah.
Hi, any timeline for when the funding will be open?
I don't have a timeline yet. Obviously, it's already taken too long, and I know that, and I'm working as fast as my little legs will go. But my intention is that we will get sign off of various big things at our September place committee, which then should allow us to hopefully start getting on with it quickly after that. But I don't want to give you an answer that I can't then meet. But as quick as possible is the short answer.
Thank you.
Thanks, Dan. Cara.
Yeah, I've got a couple of questions, if that's all right. The first one, you said that it's not, the aim of the fund is not to fill the gaps in funding for statutory services. Does that mean that it is being ring-fenced for third sector organisations, or will statutory services still be able to apply for it?
No, I think it's really important that there are partnerships. So, but those partnerships should always have should have community and third sector organisations in the partnerships.
Okay.
So the small grants certainly we don't see as being statutory stuff. Although again, if someone makes a brilliant case, okay, we'll judge it according to the criteria that are set. But for the larger partnership funding, it's envisaged that there'll always be community sector involvement and ideally they will be community sector led. But equally, if a group of GPs in a particular area has a brilliant idea and they want to work with the community sector to do something differently, then that shouldn't be excluded. And ditto, there might be frontline teams who want to do work with the community sector in different ways, and that should also still be in scope.
Yeah, that's kind of brings me on to my next question actually, which is that there's been a lot of mention around the fund about links with third sector organisations and like particularly kind of health partners, and there were quite a few on other things that I've been on. There's been questions about whether they have to be established links or whether we can look at sourcing funding to create these links with health partners, because coming from a third sector organisation, you know, the resources of establishing those links and creating those partnerships we don't often have, and so if that's a requirement before we apply for the funding, then that's going to create barriers really for a lot of organisations. So are we any further on with knowing about whether those links need to be established? Because there is also a timescale with that. We're already thinking about whether we need to be reaching out to health partners now and kind of establishing some of those links or looking at our best links already. So yeah, it's kind of, does it need to be a precursor to applying, or will we be able to factor that in terms of what we apply for and that it will be resourced through this fund?
I mean, one of the stages that we're envisaging, certainly for the larger citywide partnership funding, is that there will be an expression of interest stage. So there will be some detail released about the kind of priorities that funding is being aimed at, and there will be the opportunity for clinical leads or assigned leads with interest in those particular health themes to then do engagement, run sessions, and look to try and help those relationships build that will become the partnership proposals. So I know that's a little bit vague. I'm sorry. I don't think there's going to be any harm in you reaching out to potential partners now anyway. I don't think that's a bad thing at all. But it's just to say as well, it won't be that the fund opens, there's a deadline, and you've got to send everything in a week later. There should be that opportunity to kind of explore ideas, so that, you know, if for no reason other than just a lot of time, effort doesn't go into a bid, which is not really what was envisaged by the person who's kind of leading or seeking bids under a particular health theme, if that makes sense.
Yeah, it does. I suppose what the difficulty is not knowing kind of some of the priorities, but not necessarily knowing like how the resources are going to be allocated in relation to those priorities, because then that kind of it's a little bit broad. So I suppose having that information around the priorities even before the applications are kind of open would be really, really useful. And sorry, very last thing, I'm trying not to take up too much time, but I feel like this has kind of already been answered, but I just want to clarify it. So it seems like consortium bids will be welcomed within this from like groups of third sector organisations.
Yeah, I think so.
Yeah,
I think so.
Great, thank you.
Stephen, do you want to come in, and then I'll put Sarah on? And
so just to say a little bit, so the chief execs of the large health trusts and the directors of the significant parts of the city council have said that they're not expecting to draw significantly on this resource, so that there isn't, the perception is from the system that this is for new activity, and that lots of that activity is based in the community. That's not, I appreciate that's not an absolute commitment, but I don't think there's anything funny going on, or people don't seem to have their eyes on the money from the statutory sector. The other thing to say is, I saw it in the chat, I don't think there's been a reduction in the amount of resource available. So I think people are looking at those totals and are thinking, oh, perhaps that some of it's gone somewhere else. I think the way that Dan has laid it out previously is still in play. It's just that it hasn't yet emerged. So I think people can be reassured that hasn't been reduced. The other thing to say, and I think this, I wasn't sure whether the comment was made against which agenda item in the meeting, that lots of it's quite top down. The structures are quite top down. Obviously, the initiatives have been decided at and the priorities, although they've been done on engagement, have been decided at a system level. I think that's still a battle that we just have to keep fighting. The NHS keeps modelling its activity on itself and the City Council to a certain extent. And we need to keep pushing that. Everything needs to be modelled around citizens and those pathways and communities. And that's going to take a long time to do. So I think in all of our initiatives around the ICS, we'll keep pushing that.
Thanks, Stephen.
Thanks.
Sorry, Steph, I'm trying to take your job.
No, you're very welcome to.
No, you're better at it than me. But Sarah.
Hi, thanks, Daniel. I just wanted to flag an opportunity. I know I made reference to this early in the meeting around the Derbyshire relational model. I just think, let's try and use learning that's already happening, that's being really positive and engaging. And the reason I bring it up in the context of this point is because it was a personalised care pot of money. It wasn't particularly massive, but the one response was that the VCFSE sector were very much engaged in the how, and they wanted to remodel that it wasn't another grant and another commissioning or another kind of the same kind of process that puts them in competition, that doesn't facilitate a joining up, then coming together as a group and being responsive to those citizens. So I agree with you, Stephen, that absolutely we're doing this for the people who need it. It's our approach that I find often is the barrier, not the, and I don't think it's something that would necessarily need to take time. When I see this particular model and how it's expanded, is that actually it was done relationally. So the connection has been with the sector, and they've been very responsive to then the people and the need, and being able to immediately draw down the resource required to meet that need. And so I think there is something, again, that could be learned and maybe even applied if Birmingham were happy to open the perspective of what that could look like, taking learning from the Derbyshire relational model. I would sort of encourage it, because I am hearing this would be a fantastic investment, a way to test investment for that sector, and to try and really do things differently that could see that need being better met in our approach. So that's an offer, and I'm happy to speak one-to-one, and I'm happy to share the resources that may support that exploration, if that would be helpful, Daniel.
Yes, please. Yeah, I'll put my email address in the chat if that's okay.
Fantastic, thank you.
Thank you, Sarah.
Great, thanks, Dan. And just to say, I know that from what Dan said as well, there will be paper going to the PACE committee kind of mid-late September, and hopefully following that we'll be able to hold a session with you all, with the sector, to further engage around the Fairer Futures Fund in a way that will hopefully then answer a lot of questions that people may have at the moment, and to have that space and time to consider what an application against those different pots would look like, and how those partnerships could be supported. There's a lot of thought that is going into this, so it is taking time, which obviously isn't helpful, and we know that people want to know when the fund's going to be made available and what exactly that does look like. There's a lot of thought going into how the sector will be supported around all of this, what data will be shared, how the fund's going to be administered. So there's a lot that's being considered to make sure that it's responding to what the sector needs, that it's supporting those who will be applying, that can be done as meaningfully as possible. And there is definitely, as Dan said, there's information that you can look at in the meantime around the strategy for Birmingham, Solihull, health and equalities metrics, that will just help give you an idea as to what some of that fund is going to be positioned against. So we'll share the slides, the recording as well, as said. So if you for you to help with kind of further thinking around this, and we'll come back to you to engage on this in the coming months. Great. Okay. So I'm conscious of time, and I will go through just a brief update now on the just bear with me while I share slides on the small grants that was launched earlier this year, and organisations that were successful have been awarded the funding. So I just wanted to share some details on that with you. As said, the slides will be shared, so you'll get to kind of see this in more detail. I've listed the organisations there who have been awarded funding as part of the small grants. It was the £300,000 pot of money. There's 32 organisations with up to 10 grand that will be delivering activity within this financial year. So we've got a range of organisations and groups across Birmingham who will be delivering activity across the city or within certain parts of the city. There will be more details coming out around this. I believe there's a press release done that's going to be coming out soon. So there will be some more detail around the small grants programme organisations, information about them and their projects. What I did want to do was just to share some information around what some of those projects will look like. Again, you'll have a chance to read this. I won't go through it in detail because I do want to give space for you all if there's anything you want to share from the sector, but just by way of examples, there's support around falls prevention and dance as part of that. There will be support delivered to the LGBTQIA+ community focused around trans young people and personal self-care and mental health. There's also support that will be provided through maternity engagement action, which is very much focused around perinatal support for Black and Black mixed heritage people across Birmingham, looking at pregnancy, birth and the postnatal journey. Most Exchange will also be providing support to the Ukrainian community and building on support that they've been providing and very much focused around healthcare. Sense are also going to be looking to develop some drama workshops which will be involving people with complex disabilities and focused around safe personal relationships as part of that. And Ways for Wellbeing will be delivering support on coaching, and that's also going to be focused around mental health and support that can be provided as part of that. But I will share the slides with you so you can read through that in a bit more detail. But as said, there'll be a wider release going out so that you'll know what all of the other organisations and projects that they will be delivering across Birmingham and information around what that looks like. Unless there's any questions, I will move on to the next part of the session. And mindful we've gone through a lot this morning, and you haven't had a break, which is terrible. But hopefully you will maybe get a bit of time back at the end, depending on where we get to. So I will just move on to a brief update around the system-wide community engagement framework. There will be a more detailed presentation on this in a future meeting. There was work that's been done around April, May, June time this year, which has been undertaken by Morehouse Consulting on behalf of the Birmingham Solihull Integrated Care Board. There was a lot of scoping work, having conversations with stakeholders, holding in-person design workshops, and really looking at what was needed to support a system-wide community engagement framework, very much building on what's already there, not trying to duplicate, but to build on what's there and the learning that's there around community engagement. What does it look like? What are the challenges? What needs to be considered? And as part of that, there has been consideration about the role of the voluntary community-based social enterprise sector as part of that as well, and the role with engaging with communities. As part of the framework, they have looked at draft design principles and components around community engagement, which will be talked through in more detail in a future session. And there are essentially a number of priority recommendations that are going forward to the ICB for approval in September, which are focused on embedding best practice in community engagement. So it's a bit of a whistle-stop tour, but there will be a much more detailed presentation coming to you all from members of the comms team at the ICB on exactly what that framework looks like, what those recommendations are, and very much the role of the voluntary community sector as part of that. So we'll come back to you with more information. Any questions on that, even though it is quite a brief update? Just checking the chat. I think there are some things that I've been picked up as part of the other topics that we discussed. Okay, so this part of the session, it's really an opportunity for anyone here that would like to raise something from the voluntary community face social enterprise sector in Birmingham that you feel you want to share with the group, perhaps as a focus around integration. Could be that you've still got some questions from some of the conversations that we've been having. So feel free. I know, Caroline, you've been popping some details in the chat around the vacancy, which is great. If there is anything anybody would like to share with the group or raise, please do feel free to pop your hand up and come in. I can't see everybody now, so I'm going to stop sharing quickly. Christopher. Oh, sorry, Caroline, do you want to come in and then I'll go to Chris?
I just wanted to mention about our pilot that we are doing. It's one of 10 pilots in the country, funded by the Children and Young People's Transformation Board, NHS England Children and Young People's Transformation Board. We had already been working on this through another integrated pilot funding that the Children's Hospital had drawn down. So just in response, it's not that there's a pot of funding that people have missed out on. It's, mostly it's just within the NHS, and you're looking at a lot of vertical integration and stuff. We are unique in the country. It's a little pilot, but really exciting. And anybody who'd like information or would like to come and visit or get involved in supporting any of our outreach work, please do get in touch, because we're kind of moving into a new stage, and we're really proud that Birmingham has secured this funding. So, and we're looking for a fabulous program manager. So if you know anyone who may be suitable, please promote the opportunity. The closing date is the 31st of July.
Thanks, Caroline. Great, I'll go to Chris and then to Sarah.
Yeah, I just wanted to share with you an initiative you might think worth considering that helps smaller organisations, in that Birmingham Open Spaces Forum managed to persuade City Council to set up a seed corn fund, and from this they employ professional fund bidders who you just tell them your basic needs and they put it into a bid that's professional and will get the attention of the committees that decide these things. And I know the goodwill is there, but the big organisations like Birmingham Settlement and various others have their own professional bid writers, and the smaller organisations are competing in this playing field. And so I thought it might be an idea if the Fairer Futures Fund set money aside for the smaller organisations, so to help them make their bids. So that's just a suggestion, because I have personally, the organisation we have benefited considerably from this scheme. So I throw it out there.
Thanks, Chris. That's very helpful. Dan, did you want to come back in on that at all? I can see you now.
Yes, hello. Thanks, Chris. Yeah, we are thinking of various ways that we can provide additional support. So whether it's through kind of educational opportunities, not education, that makes it sound top down, which is what we're trying not to do, but information sharing and kind of linking smaller organisations with public health, for example, just to try and get more information about data and outcomes and evaluation, that sort of thing. So yes, thank you for that suggestion. I'll jot that down.
Great, thank you. Sarah.
Sorry, shameless plug. We have a vacancy available at Thrive Birmingham. Really excited that we are offering a community engagement officer opportunity. It is currently for 24 months. I think it's 28 hours a week. All the details are on our website and also handily advertised via the BVSC. So if anybody's interested, or you can share that with your networks, that would be amazing, because it'd be great to have somebody from the local community working with us to help us engage those hard to reach groups. Thank you very much. Shameless plug.
No problem, that's absolutely fine. Thanks, Sarah. Feel free for the link, pop it in the chat, and you might have done already and I just can't see it. That's absolutely great. We'll get that shared with everybody as well. Brilliant. I can't see any of the hands. Okay, we'll move on to any other business, and equally there's an opportunity if there's anything that you would like to share. So bear with me, I'll share slides again. It's just a couple of things to run through. So first of all, to make you aware of a funding opportunity that launched only yesterday, we received the information through NAVCA, but the fund is being administered through the National Lottery Community Fund, and it's focused on the cost of living. There's £76 million available for community organisations who are essentially delivering critical frontline services. It's open until I think it's mid-October, but they're open to applications from now onwards. Activity, from what I've read, needs to be delivered within this financial year, so up until March 2024. So the link is there. I'll get the slides across to you after the session, or I'll try and pop it into the chat. But do have a look on the website, and feel free to obviously share with your networks. Also, for those who aren't aware, we did deliver a session on Wednesday the 5th of July where we were joined by Dr. Justin Varney, who presented the 10-year strategy for Birmingham Solihull. We've put the recording on our website along with the strategy itself and the engagement report alongside of that, as well as responses to questions that were asked in the session. So again, the link is there. If you haven't seen it yet, feel free to take a look, and it will certainly help as well, building on from the discussions that we've had today, including Fairer Futures Fund. There is a session this afternoon, and I will try and get this into the chat quickly, which is focused on celebrating South Asian Heritage Month. It's being hosted by BBSC. The theme is Stories to Tell. It's taking place at 1 o'clock this afternoon till 2:30. If you haven't seen it and would like to attend and can attend, then we do encourage you to, and I'll grab the details quickly before everyone leaves and pop them in the chat. And we will be looking at the next meetings that we'll be holding. We want to time it so that you can get the most out of the next conversations that we'll have, and bearing in mind there are a few things that we're waiting to develop further, in particular around Fairer Futures Fund and what that locality partnership working looks like. So it's likely the next quarterly meetings at a locality level will take place around mid-October, so that we can bring as much as possible to that meeting to engage and to speak to you about. So we'll share details as soon as possible. In the meantime, anything that emerges that is useful to share, then we'll continue to do that through our usual channels. I'll stop sharing. I'm going to grab a couple of links, and then Caroline, if you want to come in, and Stephen.
Hi. Just also as part of any other business, the Household Support Fund, for those of you who may not be aware, is opening next week to the general public. If there are, I see, sorry, BBSC, you haven't updated your website yet, but actually if there are any high priority cases for households that you think really could do with the £200 available through this grant, you can send through to your locality teams this week, and we are prioritizing putting those grants through ahead of the whole system opening up. Just to be aware that anybody who received Household Support Fund Round 3, which was in the winter this year, would not be eligible, because there needs to be a 12-month gap between your last successful grant application for household support fund, and it's for those people in struggling to pay for food and gas, electric, etc. It's not just a general top up of holiday funds. It is for people in hardship. So, but you know, it's a really valuable grant at this time of the year.
Thanks, Caroline. That's really helpful. No, thank you for raising that. And we'll take a look at the website as well. We'll feed that back. That's great. Stephen and then Cara.
So just to say, of that £76 million around cost of living challenges, so the per capita distribution to Birmingham would be over £1 million. But one of the things that has happened historically, although it's happening less and less now, is that there haven't been enough applications coming in from Birmingham-based organisations. So definitely have a look at that as organisations. I think lots of the things Caroline raised and things that are coming through in the system governance is that lots of the stuff around the health system that people actually need isn't health support at all. It's those core things that make your life livable. So food, heating, shelter, all of those things, which this will support. So definitely when the slides come around, please encourage everyone to make applications.
Thanks, Stephen. I'll pop the link in the chat as well, so you can all start looking at that as soon as possible. Great. Cara.
I just wanted to ask in relation to the Fairer Futures Fund and the kind of possibility of kind of partnership working between other third sector organisations, whether the BVSE would be able to facilitate some of those conversations happening kind of prior to the fund being released, when we know more around the kind of priority areas, whether there'd be any opportunity to kind of because I think in terms of just making those links and knowing, you know, other organisations that might be looking at going for the fund, so that we can start that kind of partnership work as soon as possible. Because I think in terms of like health organisations, we probably will know organisations that we already have existing links with, but it doesn't always happen with other kind of third sector organisations. So I don't know whether that would be possible.
Shall I come back a step? Is that all right?
That's fine, yeah. Yep.
It's absolutely possible. We are proceeding on the basis of subsidiarity, so that the idea is that the organisations on the footprint that the money is distributed should have a role in leading, pulling those things together. We will do whatever you want us to do, essentially. So if you want us to do that, absolutely. One of the things we're very mindful of is not treading on people's toes or in their spaces. But if there's an ask out there, and I can hear that you've made that, absolutely, we'll do that.
Yeah, I'm just thinking in terms of, because I think obviously we're very good as a sector kind of working with organisations who often do quite similar kind of things to what we do, but we don't always have the links with organisations that we could work really well with but aren't necessarily in the same sector. So obviously I know a lot about other violence against women and girls organisations, but there's other areas where we may not have those links as established, but could be really useful through this fund if we're looking more broadly at kind of health inequality. So I think that's what I was thinking. Not obviously I get what you're saying in terms of not wanting to be kind of puppet master and saying you must work with this organisation, but I think just that also could be quite useful in terms of knowing what organisations are interested in this fund that we might not usually partner with, because it's quite a broad kind of funding opportunity that we wouldn't necessarily usually partner with.
Absolutely, we can do that. We'll do that. We'll connect everything together. I'm very happy if we'll both do it informally, as in if I'll put my email in the chat, and if you want to email and say this is what we'd like, we're happy to do that. But we'll also look at how we can support it more formally across the system as well. So definitely, we're happy to pick that up.
Great. Thanks, both. Brilliant. Was there anything from anybody else? We're just going to get to 12 o'clock now. Any of the business? Okay, great. So as said, we'll share the presentations, the recording with you, we'll make sure all of the feedback that's raised as part of, certainly as part of the earlier presentation around integrated neighbourhood teams, is fed back to the team. So thank you so much everyone for all your contributions, for joining us today, for giving us your time and a lot of listening as well. We'll make sure everything's shared with you, and we'll obviously be in touch with future sessions as well. So look forward to seeing us, speaking with you all again soon. Thanks everyone. Take care.
Thanks. Bye.